My beloved students, take your pens, papers, and you have your seats. Take your seats. Pens and papers are necessary, absolutely necessary, for your memorizing the notes. Memorizing, huh? For memory, all that I'm talking about. No, principle, keynotes. Okay, so today's topic is traumatic shock, my beloveds. And let's go, my dear students. So, what is traumatic shock? You open your exam tickets, of course it's a surgery questions. And definition. You start always with definition. So, traumatic shock, it's a form that occurs as a result of severe physical injury, trauma. Is characterized by a critical reduction in tissue perfusion, leading to cellular dysfunction and potentially multi-organ failure. Sorry. So traumatic shock is often the result of significant blood loss, that's hemorrhagic shock, but can be due to other factors such as damage to the heart or spinal cord. So, etiology. Traumatic shock is primarily caused by hemorrhage, massive blood loss due to penetrating of blunt trauma, for example, motor vehicle accidents, gunshot wounds, stab wounds, so-called blunt trauma. Cardiac tamponade, compression of the heart due to fluid accumulation in the pericardium, due to trauma, of course. Tension, actually the same picture pattern, but anyway, so compression to the heart due to fluid accumulation in the pericardium. Then tension pneumothorax, air trapped in the pleural space compresses the lung and can impede venous return to the heart. Neurogenic shock, spinal cord injury leading to loss of sympathetic tone and subsequent vasodilation. Severe fractures, spinal cord injury leading to loss of sympathetic tone and subsequent vasodilation. Severe fractures, so everything resembling, right, previous crash syndrome. So severe fractures, particularly of the pelvis or femur, which can lead to significant internal bleeding. Burns, large surface area burns and can lead to capillary leakage and hypovolemic shock. God forbid, God forbid. Symptoms and signs. Traumatic shock present with signs of hyperperfusion and end organ dysfunction. Symptoms may include hypertension, my beloveds, hypertension. So hypertension is what? Low blood pressure due to decreased circulating volume. Tachycardia, rapid heart rate is a compensatory mechanism. Tachypnea, rapid breathing as the body tries to compensate for metabolic acidosis. Cool, clammy skin due to peripheral vasoconstriction. Altered mental status, so ranging from agitation to confusion or unresponsiveness. Altered mental status, so ranging from agitation up to confusion or even unresponsiveness. Oliguria, decreased urine output due to reduced renal perfusion. Pale skin caused by reduced blood flow and oxygenation. Concerning diagnosis, my beloveds, diagnosis of traumatic shock is primarily clinical, based on the patient's history, obvious picture, physical exam, no, not always, always anyway, physical examination and recognition of signs and symptoms of shock. So additional diagnostic tools include vital signs, so monitoring of blood pressure, heart rate, respiratory rate, and oxygen saturation. So the classic monitoring, blood pressure, heart rate, classic in our intensive care units, respiratory rate and oxygen saturation. Focused assessment with sonography for trauma. Focused assessment with sonography for trauma, so-called FAST, F-A-S-T. An ultrasound exam to detect free fluid, blood, we understand might be blood, in the abdomen or pericardium. That's why we need FAST, focused assessment with sonography with trauma. It's essential, it's crucial. Chest X-ray to identify pneumothorax, hemothorax or cardiac tamponade. Actually, cardiac tamponade, it's okay with ultrasonography. Computer tomography scan, if you have a possibility and time, to evaluate internal injuries, particularly in stable patients, of course. Blood tests, including arterial blood gas, ABG, arterial blood gas, lactate levels. Lactate levels, we need to indicator of tissue hypoxia, lactate levels, acidosis, and hemoglobin, hematocrit levels. Of course, hemoglobin and hematocrit levels. Yes, I see. Classification, my beloveds. So classification, traumatic shock is commonly based on underlying cause. So we classify traumatic shock based on a problem. Hypovolemic shock due to significant blood or fluid loss, cardiogenic shock resulting from impaired cardiac output, often due to cardiac tamponade or myocardial contusion. So this contusion, actually cardiogenic shock, it's a cardiogenic shock, resembling actually it's not resembling, like a Killip 4. Neurogenic shock caused by spinal cord injury leading loss of sympathetic tone. God forbid, Obstructive severe shock due to mechanical obstruction to blood flow, such as tension pneumothorax or cardiac tamponade. Additional, the severity of hypovolemic shock can be classified into 4 classes based on a blood loss. Class 1, less than 50%, 15 blood loss, minimal symptoms. Class 2, 15, 30 blood loss, tachycardia, tachypnea, goes with tachycardia, tachypnea, obviously. Class 3, 30-40% of blood loss, marked hypertension, confusion, marked hypertension, confusion. And finally, class 4, we have more than 40% blood loss. So actually it's a very dangerous, life-threatening, unresponsive situation. Patient is unresponsive. Complications, so MODS, so-called MODS, MODS, multiple organ dysfunction syndrome, resulting from prolonged inadequate tissue perfusion. Acute respiratory distress syndrome, ARDS, due to inflammatory response and lung injury. It's actually respiratory failure. So lungs failure, respiratory failure. So this ARDS is acute respiratory distress syndrome due to inflammatory response and lung injury. Then we have AKI, A-K, Greek, AKI, A-K, A-K-I, AKI, acute kidney injury due to prolonged hyperperfusion, and we have the problem with kidneys. Coagulopathy caused by massive transfusion of or disseminated intravascular coagulation, famous DIC, D-I-C, disseminated intravascular coagulation. Infection and sepsis, particularly in patients with open wounds or those requiring prolonged intensive care units care. So treatment, management, immediate resuscitation, immediate, that is airway management, ensure a patient airway and adequate oxygenation, breathing, assess and manage any respiratory compromise, for example intubation, chest tube insertion for pneumothorax, pneumothorax, circulation, control external bleeding, establish large bore intravenous access, and administer crystalloids, for example normal saline, and blood products, PECT, red blood cells, plasma, platelets. Definitive treatment, hemorrhage control, surgery. So definitive treatment, hemorrhage control, surgery or interventional radiology to stop internal bleeding, treatment of specific underlying causes, needle decompression or chest tube for tension pneumothorax, periocardiocentesis for cardiac tamponade, spinal stabilization for neurogenic shock, ongoing monitoring, continuous monitoring of vital signs, urine output, and serial laboratory tests, laboratory tests, preventing complications, prophylactic antibiotics, early enteral nutrition, and appropriate use of vasopressors and inotropes. Surgical considerations. Yes, we have also surgical considerations. So damage control surgery, DCS. So DCS is what? In case of severe trauma, the goal is to control bleeding and contamination, followed by temporary closure and stabilization in ICU, intensive care unit, ICU. Definitive repair is delayed until the patient is hemodynamically stable. My beloved surgery students, surgeons, John. Timing of surgery. So immediate surgery is indicating immediate surgery. It's a surgery question, my beloveds. So immediate surgery is indicated for life-threatening injuries, while less urgent cases may require preoperative stabilization. Minimal invasive techniques. When appropriate, minimally invasive techniques such as angiographic embolization can be used to control hemorrhage without the need for open surgery. So, my beloveds, traumatic shock is a critical condition that requires immediate recognition and aggressive management. Understanding the underlying cause, classification, and potential complications is essential for providing effective care. Surgical intervention is often necessary to control the source of bleeding or other injuries contributing to shock. So that absolutely, so familiarity with the principles of resuscitation and management of traumatic shocks is a fundamental to practice of emergency medicine, trauma medicine, etc., etc., etc. Largely sufficient, absolutely more than sufficient for your excellent answer on your state big exams, clinical exams for surgery. So of course you don't have 13 minutes to answer. Anyways, try to be specific. Doesn't matter what is question exact. You start with definition of the problem and then goes into details. But from the beginning, try to be specific. Thanks for your attention. Follow and subscribe my channel in Dr. Y, so put the ring on. Don't forget to follow not only the videos, it's okay, but follow also the community. A lot of surprises you will see. Gifts, presents, etc., etc., etc. Exam questions, your tickets, exam tickets, and other gifts and presents. Yeah. So God bless you. See you in the next lectures.